Hello everyone. Today I will be discussing ESOPEC trial, a phase 3 randomized study recently published in the New England Journal of Medicine in 2025. We directly compared perioperative chemotherapy with the FLOT regimen against neoadjuvant chemoradiotherapy with a cross regimen in patients with resectable esophageal and gastroesophageal junction adenocarcinoma. Surgery remains the cornerstone of curative treatment in esophageal and G-junction cancers. However, long-term survival with surgery alone has been limited, with 5-year survival rates historically around 20 to 30%. These outcomes have driven the evolution of multimodality treatment, combining surgery with systemic therapy and local regional approaches. Over the past 2 decades, two major strategies have become well established: neoadjuvant CTRT, pioneered by cross trial, and perioperative chemotherapy, subsequently optimized through the FLOT regimen. Cross trial, published in 2012, was a landmark phase 3 study. It randomized around 368 patients with resectable esophageal or gastroesophageal junction cancers to either surgery alone or preoperative chemoradiotherapy, consisting of weekly carboplatin and paclitaxel with concurrent radiotherapy to 41.4 gray. The results were practice changing. The median overall survival improved from 24 months with surgery alone to 49 months with chemoradiotherapy. The 5-year overall survival was 47% versus 34%. Importantly, cross also increased the RG resection rate from 69% to 92%, and the pathological complete response rate reached up to 29%. When we examine histology specific outcomes, in squamous cell carcinoma, the benefit was particularly striking. Median overall survival was 81 months with chemoradiotherapy versus 21 months with surgery alone, corresponding to a hazard ratio of around 0.48. Pathological complete response rates were nearly 50%. In adenocarcinoma, the benefit was present but less dramatic. Median overall survival improved from 27 to 43 months with hazard ratio of around 0.73, and the PCR rates were around 23%. Thus, cross became standard of care worldwide for esophageal squamous cell carcinoma with unequivocal survival and local control benefits. For adenocarcinoma, although it was beneficial, the survival improvement was less profound and systemic relapse remained a challenge. In parallel, the FLOT trial reported in 2019 refined the perioperative chemotherapy for gastric and G-junction adenocarcinoma. It compared the intensive FLOT regimen with the older ECF regimen. FLOT significantly improved the outcomes with median overall survival of approximately 50 months compared to 35 months, establishing perioperative FLOT as the standard chemotherapy backbone for gastric and G-junction adenocarcinoma. With these results, question was still there whether FLOT regimen was better for adenocarcinoma compared to the cross regimen. So there were many studies. Among them, NEJM trial, which published in 2023, attempted to directly compare neoadjuvant chemoradiotherapy with perioperative chemotherapy. However, most patients in the chemotherapy arm did not receive FLOT, only about 15% did, limiting its ability to settle the debate. NEJM found no significant difference in overall survival between strategies, but questions remained. Despite these advances, a crucial question persisted. For resectable esophageal adenocarcinoma, which strategy is superior, perioperative chemotherapy or neoadjuvant CTRT? Cross was highly effective for squamous cell carcinoma but offered more modest gains in adenocarcinoma, with systemic relapse remaining common. FLOT was clearly superior to older chemotherapy regimens but had not been directly tested against cross in this population. Thus, ESOPEC trial was designed to provide a head-to-head comparison of FLOT and the cross in pure adenocarcinoma, with overall survival as the primary endpoint. ESOPEC was a phase 3 randomized open-label trial conducted at 25 centers in Germany. Eligibility criteria included patients with clinical T1 N plus or T2 to T4A NEN with M0, adenocarcinoma of esophagus or G junction, ECOG performance status 0 to 2. Patients were randomized to 1:1 to FLOT versus cross, stratified by center and nodal status. In the FLOT arm, 4 cycles of perioperative chemotherapy before surgery, followed by surgery, and then 4 additional cycles given postoperatively. In cross arm, weekly carboplatin and paclitaxel for 5 weeks with concurrent radiotherapy to 41.4 gray, followed by surgery. Surgery consisted transthoracic esophagectomy or external gastrectomy with 2-field lymphadenectomy. Surgical quality was excellent. with RZ resection rates above 94% in both the arms. Primary endpoint was overall survival. Secondary endpoints included progression survival, R0 rate, pathologic response, recurrence patterns, and toxicity. With a median follow-up of 55 months, the trial enrolled 438 patients. 3-year overall survival was 57% in FLOT arm versus 50% in the cross arm. 5-year overall survival of 50% versus 38%, and median overall survival was 66 months with the FLOT and 37 months with cross, with hazard ratio for death of 0.7 with a p-value of 1.01. 3-year progression-free survival of 51% versus 35% with hazard ratio of around 0.6. These results establish a clear survival advantage for perioperative FLOT versus cross in adenocarcinoma. Pathologic complete response of 16% with FLOT versus 10% with the cross, and node negative rates approximately 50 to 55% in both the arms. Local regional recurrence was more common with the FLOT, and distant metastases were more common after cross, highlighting the systemic disease control advantage of chemotherapy. Grade 3 or more adverse events occurred in 58% with the FLOT and 50% with the cross. FLOT caused more hematologic and GI toxicity, while cross caused more pulmonary toxicity and esophagitis. Completion rates were lower in the FLOT arm, with just over half completing all 8 cycles. And looking at the postoperative mortality, at 90 days, it was similar, 3.1% versus 5.6%. Looking at the strength of the study, it was a phase 3 randomized control trial, which provides high level of evidence, and multi-center participation. Up to 25 German centers were participated with a large sample size of around 438 patients, and it directly compared two established standards, FLOT versus cross, which resolves a long-standing clinical question. It had a clear and clinically relevant primary endpoint of overall survival with appropriate secondary endpoints. Looking at the quality of surgery, it had high R0 rate, more than 94% across the both arm, reducing confounding due to suboptimal surgery, and central pathology review ensured diagnostic accuracy and uniform eligibility. The study had adequate follow-up data with median follow-up of around 55 months, sufficient to detect long-term survival differences, and practice-changing results directly applicable to the treatment guidelines, especially in Western population with adenocarcinoma predominance. Looking at the limitations of this study, it was an open-label design with a potential bias in perioperative management, toxicity reporting, and follow-up. And compliance issues in the FLOT arm, only 50% completed all the 8 cycles, questioning real-world feasibility. And higher acute toxicity with the FLOT regimen, higher hematologic and GI toxicity may offset a survival benefit in frail population. And there was no mandated molecular stratification, limiting the precision oncology insights. And radiotherapy limited to 41.4 gray, and some centers might consider this suboptimal dose for definitive local control. And limited reporting on recurrence patterns, local versus distant relapse, not deeply analyzed in molecular context. Cross regimen was underdosed for systemic control with a chemotherapy backbone of carboplatin with paclitaxel may not match the modern systemic therapy standards. Looking at the clinical implications of this study, for adenocarcinoma of esophagus and GE junction, ESOPEC demonstrates that perioperative FLOT chemotherapy offers superior overall survival and progression-free survival compared to cross. This strongly supports FLOT as the new standard of care in this setting. For squamous cell carcinoma, still cross remains the standard, as ESOPEC did not study the squamous cell carcinoma, and prior data showed dramatic benefit with the chemoradiotherapy in this histology. In adenocarcinoma, patients unfit for FLOT or with bulky local disease requiring downstaging, cross may still be appropriate. And my questions to the editor. First one is, only about half of the patients in FLOT arm completed all 8 cycles. How might this level of compliance affect the interpretation of long-term outcomes, particularly in routine practice where tolerance may be even lower? The cross protocol utilized 41.4 gray of radiation. In several contemporary protocols, higher doses up to 50 gray are still considered for local control. Could this have placed the cross arm at a relative disadvantage in this trial? Looking at the recurrence patterns, the report briefly mentions differences in the locoregional and distant recurrences between the arms. Could the author provide more detailed subgroup analysis of recurrence pattern, especially by nodal status and tumor location? Esophageal cancer treatment often entails significant morbidity. Were patient reported outcomes collected? And if so, when will they be available to contextualize the survival benefits against the functional outcomes? Thank you for joining this Journal Club discussion. Thank you.